All of these factors weigh into the determination as to whether it is valuable to catch cancer early. It is not a universal good, and it is not a simple analysis. We have been fooled into thinking that it's a simple analysis by overly simplistic views of how cancer works. We got it into our little heads that early detection was the key. And we took that and we expanded it to everything, everywhere, all the time. There is no detectable difference in any age group on overall mortality from breast cancer screening. The idea that finding small, treatable cancers will save lives by stopping them from growing into larger malignant cancers is appealingly simple. It was thus disappointing when the evidence from randomized controlled trials was underwhelming. So, we've got a bit of a provocative title here today. But this is in response to a pretty remarkable trial that just came out, the Nordic trial. And I think that this trial points out the flaws that we have in our thinking, in our philosophy, in our approach to wellness. And since that's one of the major focuses of my practice, I think that it would behoove us to not only go through that study, but the entire line of studies in the preventative field, and to show the flaws that are starting to manifest. So I'll cut to the final thesis here, just so that you know where we're going. Fundamentally, the techniques, the thought pattern, the methods that we use to diagnose and treat illness will not work for wellness. They will not work to promote health, and frankly, they're deeply flawed even for the concept of prevention. So things like checking blood work, things like trying to optimize your lab values, things like trying to get whole body MRIs or other imaging or fancier blood tests or early detection. These are flawed concepts, and that goes against a great deal of our cultural narrative. First, I want to talk about what it takes to have a good screening test. What are the factors that go into screening for disease? Well, first of all, the test has to be accurate. And I talk about that at length, and I'll post a link up here in my analysis of how to deal with test accuracy and inaccuracy. It's a bit of a lecture on its own, but all medical tests are subject to error, both false positives and false negatives. Thanks to COVID, that concept has started to enter the public consciousness, but keeping it in mind, even for something like a screening test, is really important. If mammograms have a high false positive rate, then you're going to do a lot of unnecessary biopsies. Out of those biopsies, some of the pathology readings will be wrong, and women who don't have cancer will be given chemo and radiation and surgery. That's inevitable. Overdiagnosis has measurable harms. Some of those women, a small fraction, will die from the chemo and radiation, or will develop subsequent cancers from the chemo and radiation for breast cancer that they didn't have in the first place. So you have to choose very carefully how high of a false positive rate you're willing to tolerate, because the harms are not just theoretical. The harms are real. And when you are talking about a screening test for all women over a certain age, that is millions and millions of women. So small percentages are going to add up. 0.01% of a million is still thousands. And if we are talking about thousands of women that may end up dying from treatments that they didn't need, for breast cancer that never existed, but was an overdiagnosis from an overly aggressive screening program. That's something that should give us some pause. So that's the first thing to consider, is how accurate are the tests? What are the risks of over and underdiagnosis? And if you want a really detailed explanation or examination of that concept, like I said, you can check out the video. I'll link it here, and I'll also link it in the description below. Next, we need to consider, what is the safety of the test? With colonoscopy, the concern of perforating the colon during the test, or the concern of generating arrhythmias of the heart or cardiac events from the dehydration and electrolyte abnormalities that come from doing a full bowel prep and having that severe, massive diarrhea that cleans out your bowels so that a colonoscopy can be done. Those harms are things that should be considered. Another thing to consider is, how effective are our treatments for these diseases? If I have a fantastically accurate screening program and I catch a particular cancer very early, but we have no effective treatments for it, well, then what good is the screening program? Because all it does is give people anxiety for a longer period of time until they die, because we have no known treatments. So the effectiveness of the available treatments is critical to consider when we're talking about screening programs. This is actually a tremendous issue in cancer screening research, called lead time bias. And what it means is, let us suppose we have godlike knowledge. And over the course of someone's lifetime, they develop cancer at a certain point and they die at a certain point. Now, between development and death, that cancer could be detected here, let's say. And they have a certain amount of time before they die between detection and death. Let's say that's 10 years arbitrarily. Now, what if we can detect it earlier? Well, if treatments are not very effective, they would die at the same time. And all that would happen is they would live with the knowledge of their cancer for 12 years. If they undergo treatment, those treatments could be painful, uncomfortable, cause other side effects, including heart attacks, sepsis, strokes, other cancers. And they would start on that process of misery 2 years sooner, without any change in their final outcome. One of the tremendous problems that we see in research is the publication of the 5-year survival rate. And the reason that's a problem is that if most people who were diagnosed with this cancer, say, instead of a 5-year, let's say it's a 10-year survival rate, right? Well, the 10-year survival rate here is going to be very low. But the 10-year survival rate here is actually going to be great, right? Because everybody dies 2 years later. But you didn't actually change the time that they died, but by detecting it earlier, you improved the 5 and 10-year survival rate. So once again, how we publish statistics can be tremendously misleading. And we've seen this in action, in fact, in discussion of the PSA, comparing the US to the British system. They said, well, the 5-year survival rate in the UK is much less than the 5-year survival rate in the US. But in reality, the mortality from prostate cancer wasn't different between the two countries. But because of over-screening in the US, we detected that prostate cancer early, and so the patients lived for a longer period of time knowing that they had cancer and had a longer 5-year survival rate without any change in mortality. And so that's important. Changing mortality should be more important to us than 5-year survival rates. Part of what I'm doing here is trying to teach patients how to read medical literature. If it says only 5-year survival rate, if it says only relative risk reduction, you can throw that paper out. Now we're going to get into other things you can throw papers out about. Notice that I said mortality. Well, once again, even within something that should be so crystal clear as mortality, there's a great deal of statistical chicanery that can be done. And the difference here is between what we call all-cause mortality, and you'll have to forgive the doctor handwriting there, and disease-specific mortality. So with disease-specific mortality, it means the likelihood of dying from a particular disease. What is the likelihood that someone who is not taking a statin or is taking a statin dies of a heart attack? All-cause mortality is what is the likelihood that someone that is taking a statin or doesn't take a statin dies at all within a specified period of time, say 10 years. And the reason this is important is, what if the drug increases your risk of dying from something else? With statins, the usual hypothetical example I give, and this is not real, I want to be clear, but the hypothetical example I give is statins can cause muscle weakness and muscle pain. What if people experience so much muscle weakness that they stumble and get hit by buses? And so, yes, they are much less likely to die of a heart attack, but their bus mortality goes up. And so there's no change in the all-cause mortality. And that is, in fact, what we see with statins. That for primary prevention, not secondary prevention, but for primary prevention, there is very little change in all-cause mortality. When it comes to cancer screening, most of the time, statistics are published for disease-specific mortality. And that's problematic, because if treatment for cancer increases your risk of heart attacks, then the breast cancer screening or the colon cancer screening may reduce your risk of breast cancer death, may reduce your risk of colon cancer death, but actually may not reduce your risk of death overall. That's a tremendous problem. The other thing to consider is the natural course of a disease. So, prostate cancer in particular is so common in elderly men that the saying in medicine is that you are more likely to die with it than die of it. And what that means is that if you are an 80-year-old or a 90-year-old man who has prostate cancer, you are far more likely to die from a heart attack, stroke, or an infection than you are to die from that prostate cancer. So treatment then is not particularly valuable. Finding the cancer is incredibly useless because you're not going to treat it anyway. So choosing who we screen is not a simple matter. Finding the cancer is not particularly important if you are not going to treat it. In particular with prostate cancer as well, what we are finding is that our screening methods are so inaccurate, and the harms of prostate radiation, surgery, are sufficiently significant that it may not be worth doing the screening at all in anyone, because most prostate cancer is not aggressive. And we do not yet have good methods of determining which prostate cancers are going to be aggressive. And so we end up, for legal reasons, treating all prostate cancers as potentially fatal, even though we know that's not true. And we do the exact same thing with breast cancer. Not all breast cancer will progress, or progress fast enough to be the cause of death. So in all of this, I've been talking about death. And the reason I talk about death, as I've talked about elsewhere, is because it's a very clear clinical endpoint. There's very little debate about the definition. If someone died, especially all-cause mortality, we can debate a little bit as to whether the cancer caused the death or if something else caused the death. But all-cause mortality is a very clear statistic. And one of the reasons we look at it is because if we see a drop in all-cause mortality when we start doing a screening program, then we can say that the screening program is worthwhile, assuming there are no other factors, which is tricky in itself, and we can talk about that as well. But of course, that's not the only thing we really care about. We care about more things than just mortality. We care about pain. We care about weakness. We care about shortness of breath, nausea, neurologic dysfunction. Not only can the disease cause those things, but the treatments can cause those things. And it is not clear at all which is worse. The suicide and heart attack rate from prostate cancer treatment or after prostate cancer treatment is actually significantly increased. Some of that may be erectile dysfunction. Some of that may be pain. Some of that may be other discomforts that we're not aware of, the need to catheterize. The full analysis is really not something we can do because it's actually even specific to the individual as to whether they would rather be impotent and alive or whether they would rather die. Would they rather be alive if they have to have a catheter draining their urine all the time? Or is that a level of discomfort and suffering that they would find undignified and not ethically acceptable to them? All of these factors weigh into the determination as to whether it is valuable to catch cancer early. It is not a universal good, and it is not a simple analysis. We have been fooled into thinking that it's a simple analysis by overly simplistic views of how cancer works, how treatment works, and the value of those things. One of the major themes that I talk about on this channel, that I talk about with my patients, is that you cannot extrapolate from one area to another with no loss of accuracy. I think one of the phenomenal harms that has happened in medicine is trying to project from treatment to prevention and to think that we're going to be able to do that fluidly. I've used statins before because they're sort of the poster child for this, but statins are very effective in preventing the second heart attack, or preventing a heart attack in someone that we know has heart disease. When I say very effective, it's a reasonable percentage reduction. But for people that do not have heart disease, the risks likely outweigh the benefits. You cannot simply extrapolate from one to the other. I think we became very enamored of the idea of pills as treatments during the first flush of the antibiotic era. One of the major causes of death, misery, loss of loved ones was infection. And we seemed to have mastered that with the development of these pills. And then we thought, well, maybe we can get a pill for everything. Maybe every form of suffering can be alleviated just by taking a pill. And so we developed pills to prevent heart attacks. And we developed pills to improve mood and anxiety and pain. And now we have an epidemic of opiates killing people. We did not realize that when you block the body from pain, often it upregulates your pain receptors and you end up with opiate-induced hyperalgesia. You are more sensitive to pain because you have blocked your pain receptors and your body is trying to compensate. When you withdraw off of benzodiazepines, you have anxiety and insomnia. And so they are addictive. And the withdrawal can kill you. And as tolerance increases, you still end up with anxiety. We finally did a study for SSRIs and depression, and there was no improvement in quality of life after 3 to 5 years. There is not a pill for everything. A similar process has occurred with the idea of blood work and imaging. Blood work is phenomenal for detecting illness, because if your blood work is sufficiently abnormal as to be far outside the range of normal, it is likely that it reflects an underlying disease. If you have symptoms like pain or nausea or tenderness or neurologic dysfunction, and we do some sort of X-ray, some sort of MRI, some sort of imaging, it can be very useful to help us confirm or disconfirm diagnoses, because you have a high pretest probability. Your symptoms put you in a group where the probability of some sort of illness is already very high. If you try to use blood work or imaging in patients who they're not patients actually, in people who do not have any symptoms or any problems, you end up with a tremendous number of false positives and no measurable benefit. That has been shown over and over again. The methods are flawed. We keep trying to extrapolate from early success in a specific area to just everything, everywhere, all the time. It doesn't work. It didn't work with antibiotics. It isn't working with blood work, and it isn't working with imaging. We need other methods. Part of what I'm doing at River Rock is trying to develop those methods. We can talk more about that in other videos. But the key point is, do not try to extrapolate from success in a disease context to success in a wellness context. Blood work does not contain the information you're looking for. Similarly, what we are finding is that screening tests are not universally effective. Early detection, quote unquote, does not lead to reductions in mortality. Let's get into it. Where should we start? Let's start by considering mammograms. This is a paper published in 2021 discussing mammograms and mortality. That is the key factor. Once again, remember, we are talking about all-cause mortality. We're not talking about disease-specific mortality. This author even does a great job of going through the history of mammograms and how we came to establish our current mammogram recommendations. Notably, it started with cervical cancer, the Pap smear. The publications on Pap smear, this is a more recent study than 1973. This was 1994 this was published, but there was a reduction of 50% in cervical cancer mortality. Now, that is disease-specific mortality. That's an important difference. However, these are young women overall, between 40 and 60 years old, 40 and 70 years old. So preventing cervical cancer deaths in that population, because they had a pretty low risk of death to begin with, dropping that by half was probably significant. And that was the early success that led us to the idea that early detection was important. And I want you to pay attention to that moment, because we got it into our little heads that early detection was the key. And we took that and we expanded it to everything, everywhere, all the time. Let's go back to mammograms. Decades of evidence reveal a complicated relationship between mammograms and mortality. That is hardly a ringing endorsement, is it? Let's get into the complications. Mammograms may detect deadly cancers early, but may also lead to the diagnosis and potentially fatal treatment of cancers that would never progress to cause symptoms. Mammography can detect some early-stage cancers that will never progress to cause symptoms, referred to as overdiagnosis. In such cases, the emotional, financial, and physical costs of a cancer diagnosis and any subsequent treatments occur without any corresponding health benefit. Because it is hard to tell which women will be harmed by their cancers, there is a tendency to treat all women as if their cancers will be lethal, even if the initial cancer would have never proven life-threatening. Exposure to chemotherapy, radiotherapy, and surgery can potentially lead to new conditions. These are exactly the same things I've talked about. In all age groups, mammography has increased dramatically. And here is the chart. Mammogram within the last 2 years, markedly elevating since 1987 to 2015. Here is the breast cancer incidence by stage, 1975 to 2015. Early stage breast cancers took a tremendous leap up. We were catching it early, right? Once again, overdiagnosis is difficult to identify. If a mammogram catches an early stage cancer, it is impossible to discern how that cancer would have progressed absent detection, especially for a given individual. Several types of evidence suggest overdiagnosis. For instance, autopsy studies showing that almost half of older men die with, but not necessarily of, prostate cancer has been important to prostate cancer screening guidelines. Autopsy studies also suggest overdiagnosis of thyroid and breast cancer, and time series evidence suggests overdiagnosis of thyroid, melanoma, and kidney cancer. As diagnoses have risen dramatically with screening, deaths from these types of cancers have been stable. Once again, we are detecting it early and having zero impact on mortality. Deaths from breast cancer have decreased as mammography has increased, but differences in the decreases across geographic areas suggest overdiagnosis. The greatest reductions occurred in countries where screening was less common. So there may be some value in some screening, but more screening may not provide additional benefit. Blair and Welch in 2012 provide an approach that quantifies overdiagnosis from screening. The goal of screening is to prevent early-stage cancers from progressing to a later stage. Therefore, an increase in early-stage cancers without a decrease in late-stage cancers of the same magnitude indicates overdiagnosis, under the assumption that late-stage cancers will be detected regardless of screening. This is a critical point, is that if a screening program is effective, yes, you should catch more early-stage cancer. But there should also be a decline in late-stage cancer that is the same amount as the increase in early-stage cancers you detect, because you are preventing the early stage from moving to late stage. That's not what we see. This is indicative more of overdiagnosis than effective screening. Evidence of overdiagnosis from randomized control trials is the most compelling. Trials should find a higher rate of cancer in the intervention arm in the short term, and in the long term, if the only impact of screening is to detect cancer early, rates of cancer should converge in the intervention and control arms. A failure to converge after a reasonable amount of lead time indicates overdiagnosis, and overdiagnosis became apparent in the lung cancer screening trial based on 16 years of follow-up data. Since then, overdiagnosis has become apparent in 2 studies of mammography trials based on at least 15 years of follow-up data, which imply overdiagnosis rates of 5 to 55%, depending on the subgroup and base rate. The author points out overdiagnosis, though undesirable, might be tolerable if screening reduces mortality. So, the rest of this paper is evaluating mortality. The 2016 guidelines for mammography screening from the USPSTF are based on meta-analysis. All trials combined include over 600,000 women. Overall, the meta-analysis finds no statistically significant reduction in all-cause mortality for women in any age group. Some trials even show imprecise increases in all-cause mortality across all age groups or within an age group. Results focused only on breast cancer mortality are slightly more promising. Meta-analysis finds statistically significant but small reductions in breast cancer mortality for women in their 50s and 60s, and finds imprecise reduction for women aged 39 to 49. We're going to review those trials, but once again, consider this. If there is a decrease in breast cancer deaths, but there is an increase in other deaths from anything. That could be from getting hit by a bus. That could be from the side effect of treating breast cancer. That could be from anything. But if these two things occur together, then there will be no change in all-cause mortality. So for the rest of this, let's focus on deaths from breast cancer and all-cause deaths. This first chart, Table 2, shows each trial included in the meta-analysis and what its commentary was on the effects on breast cancer mortality. That's disease-specific mortality. What I want to focus on is this confidence interval. When a confidence interval crosses the number 1, if the number 1 is between these two numbers, the finding is not statistically significant. I want you to notice how many trials found no statistically significant difference. Each one of these includes the number 1. Every single trial that has ever been run in women aged 39 to 49 years has not found a statistically significant reduction even in disease-specific deaths. As a result, the USPSTF increased the recommended screening age to age 50. Even in this population, almost every single trial found no statistically significant reduction. This trial did. Notice that this range does not include the number 1. This was, I believe, a Swedish trial. This trial found a benefit, and this trial found a benefit. Out of 8 trials that have been performed in this age group, 3 found some benefit in breast cancer-related mortality. This is disease-specific mortality. In women aged 60 to 69 years, there are a few more studies. 4 out of 6 studies found a statistically significant reduction in breast cancer mortality. So, age 60 to 69, there may be some value in reducing breast cancers. And once again, after age 70, each and every trial includes the number 1, no statistical significance. Let's look at all-cause mortality. Once again, the number 1 is included in virtually every single number. Even the estimates are at 1, by the way. Even the mean is at 1. There is no detectable difference in any age group on overall mortality from breast cancer screening. This is the difference between disease-specific mortality and all-cause mortality. Once again, here we see that there was 0 difference in all-cause mortality. You may have reduced deaths in women aged 60 to 69. You may, if you squint at it, reduce breast cancer deaths in aged women 50 to 59. But women died at the same percentage rate despite those reductions, even at those ages. They just died from other things. In the commentary here is a really critical bit of information. It is hard to understate the controversy surrounding the results from mammography trials. The idea that finding small, treatable cancers will save lives by stopping them from growing into larger malignant cancers is appealingly simple. For advocates of mammography, it was thus disappointing when the evidence from randomized controlled trials was underwhelming. As a starting point, this author examines breast cancer mortality and all-cause mortality 20 years after enrollment in the study, which is the maximum follow-up length available. What he found is that breast cancer deaths were reduced by 20 fewer deaths from breast cancer per 100,000 women, a very tiny fraction. There is a slight increase in all-cause mortality rate of 89 per 100,000. a fewer number of women died of breast cancer, and a slightly higher number died overall in the mammogram, no mammogram group. Why would there have been an increase? There are many mechanisms that could explain the trend in all-cause mortality. Breast cancer treatments could have mortality impacts that are not captured by breast cancer mortality. Randomized controlled trials of radiotherapy show that it increases lung and esophageal cancer mortality among women treated for early-stage breast cancer. From these three causes combined, I find an additional 3.6 excess deaths per 100,000 women. This trend is statistically significant, and it can explain more than half of the trend in all-cause mortality. How have our institutions responded? One response is to incorporate it into new policies. The USPSTF ties health insurance coverage for preventative services to current and future guidelines of the USPSTF. However, the Affordable Care Act makes an explicit exception for mammography, allowing coverage for annual mammograms for women in their 40s despite current guidelines. The political and cultural factors are divorced from the science. And the political uproar of not covering mammograms that harm women and increase their risk of death have prevented it from falling out of healthcare coverage. For example, in California, state auditors implemented a policy that required many elderly women enrolled in a particular health plan to receive at least one mammogram. The average age was 81. Unsurprisingly, 17% of these women experienced significant burdens from mammography. The policy was later reversed, but the issue of screening older women persists. One doctor told Kaiser Health News that doctors continue to screen older women because of fears of lawsuits, health system bonuses for high screening rates, and because doing less can be perceived as a lack of caring or ageism. It can be uncomfortable for a physician to explain why doing less is more. In my paper on COVID, I discussed Brandolini's principle, which is also known as the bullshit asymmetry principle, which is that it takes an order of magnitude more time, effort, and energy to refute bullshit than it does to generate it. That is not just true of bullshit. That is true of even honest intentions that are based on a cultural narrative that is false. That intervening is our best option. Catching things early is what we should do. More monitoring, more screening, more tests. Broader tests. Test more of my body. MRI my whole body. Do every blood work you can. Measure everything. Quantify the self. This is flawed reasoning. It is difficult to communicate with patients where the reasoning is flawed because it is so woven into our culture. It is wrong. And we are seeing more and more that it's wrong. But the science is not enough yet to counteract the cultural assumptions. I won't go through this whole paper because we need to get to the Nordic trial. But PSA for screening for prostate cancer, once again, recommended against screening at any age because it does not work. It is not a good screening test. You do not catch cancers that will cause death. A higher rate of metastatic progression was observed in the active monitoring group for PSA than in other groups, a difference that began to emerge within 3 to 4 years. However, that difference did not translate into a difference in prostate cancer death rates even after 6 to 7 more years of follow-up. It is tempting to use other data sources, which may be available sooner, to assess the effects of reduced screening. However, the potential for misinterpretation with such sources is great. This is once again a cultural narrative we cannot let go of. We want our results. We want it now. We don't want to let things play out and figure out the truth. We think that if we can just throw enough big data at it, it'll give us the answer soon, now. It doesn't. It leads us down blind alleys far too often. And in medicine, there are lives at stake down those blind alleys. There is a critical need for strategies to reduce the burdens associated with the diagnosis of indolent disease through a combination of not diagnosing it in the first place and accurately classifying it as not needing any further follow-up or treatment, while still maintaining any mortality benefits for men with aggressive disease. Perhaps that is the most pressing research challenge going forward. So this is all in regards to the PSA. So once again, I think the challenge we face is in dealing with our flawed attempts to generalize thought processes. Early detection seems to have worked quite well for cervical cancer screening. Though, to be fair, we're also backing off on the frequency there. We're recognizing that the HPV vaccine may make it less useful to do pap smears in the future. We will have to wait to find out. Just because we had success in one area does not mean that early detection is going to be a successful strategy in every other area. This applies to whole body MRIs. You may detect a tumor that may never become clinically relevant. You'll be anxious about it. You'll have it biopsied. The biopsy may have side effects. It may find cancer. Maybe that cancer would never grow to anything. Maybe your immune system would kill that cancer before you ever found out about it. Your immune system does that, by the way. A lot of people don't realize that your natural killer cells do kill cancer. But we see, even in the breast cancer literature that I went through, a significant effect of overdiagnosis. And that means that likely some of those tumors that were found would never have progressed throughout the lifetime. How much more foolish is it to start hunting for potentially irrelevant tumors, undergoing multiple risky procedures to characterize those tumors, treat those tumors, chemo, radiation, for the illusion of having done something. One of my favorite mentors used to say, don't just do something, sit there. And we've lost that in medicine. We've lost that in our culture. Intervention, action is not always better than inaction. Bad action is worse than inaction. For whatever reason, it is very difficult to communicate to patients that unnecessary testing is a bad action.